Today we bring you a case of phaco and a very dense cataract, performed by an elite-level surgeon, and the aim of this video is to show that even with a posterior capsular rupture it is possible to successfully finish the case with an IOL in the capsular bag. No trypan blue is used for the rhexis. As with experience you can notice the fine contrast detail of the capsular margin as you direct the tear inwards. A 26-gauge needle may be needed to redirect the direction of this elastic capsular tear inwards, and with controlled circular tearing the rhexis is complete. Careful hydrodissection is performed. Now we advance to Phaco by creating a very deep sulcus. High ultrasound power and lower vacuum and aspiration rate should be used to minimize the traction on the zonules. The surgeon should aim for about 3 Phaco tips depth before attempting to split the nucleus. After deliberate sculpting, a partial crack is achieved. Now the strategy is to slice small segments of the nucleus. This is done using a sort of impale the tip and push with a chopper technique. Finally, a small quadrant is cleared, making it easier to mobilize the rest of the dense nucleus. As more nucleus is removed, the capsular bag is prone to fluidic chamber fluctuations and surge. In fact, while emulsifying the last quadrant, for an instant of a second the phaco piece touches the posterior capsule and instantly creates a large round tear. The surgeon, realizing that there is a large tear, aims to push the dense remaining nucleus to the anterior chamber and fill the capsular bag with dispersive OVD. As the bag distends with visco, we can clearly see that the tear is round and somewhat centered, meaning that the capsular bag can accommodate a safely placed intraocular lens. The IOL is then implanted and acts as a scaffold over which the remaining nuclear quadrant will be removed. The lens is stable and centered, and as usual with these very dense cataracts, there is no significant cortical material to remove. A very important tip: before removing the phaco piece, a syringe filled with air is requested for the left hand to inject an air bubble in the anterior chamber, minimizing chamber fluctuations and a possible extension of the tear or IOL displacement. The pupil is round, the lens is stable, so it's time to hydrate the corneal incisions, inject antibiotic, and this very tough case is successfully complete. Thank you for watching and stay tuned for more.